Welcome to this episode of the Biology of Trauma podcast. I'm your host, Dr. Aimie. Should health providers include trauma in what might be a reason for a patient's symptoms? In this episode, we'll be talking about trauma-informed medicine, what it should look like. Because with all the information that we have on how trauma is in the body, not just the mind, we can do better. The modern health provider can do better by asking better questions, learning to recognize trauma as a contributing factor to symptoms, and not call patients crazy when tests can't find anything wrong. I have an incredible guest for this episode, Dr. Jarina Albers, a board-certified physician in neurology with a master's in epidemiology and former assistant professor and pediatric neurologist at Stanford University. She has authored over 25 research articles and book chapters, and now really focuses on what's going on in the nervous system in regards to stress and trauma, how to recognize it, and how can health providers do better. She is currently the director of the Trauma Recovery Project at HeartMath Institute. She runs her own trauma-sensitive neurology clinic. And I am very excited to share with you that we are working on a project and program together on trauma-informed medicine for the modern health provider. Be sure and check the link in the show notes for each of you who is a health provider and wants to join this community and this movement. We are starting to change the conversation for medicine and the clinical applications for trauma stored in the body. In this podcast episode, you will hear Dr. Albers, her journey of how she discovered this link between trauma, stress, and neurological disorders. Like many of you, this is not just her professional training and experience. This is going to be a personal story of her own unhappiness and where that led her. You will learn how to ask better questions that lead to discovering the true causes behind seemingly inexplicable diagnoses, what tools can healthcare practitioners integrate into consultations to uncover patients' trauma history and why this is so important, the importance of including trauma in differential diagnoses, especially when conventional medical tests don't reveal a clear cause, how to move away from treating symptoms on a superficial level, like neurotransmitters, and into treating the whole nervous system, the autonomic nervous system and heart rate variability, and finally, medical trauma, from procedures and treatments that actually contribute further to one's symptoms and chronic conditions. What do you think? Should health providers include trauma in what might be a reason for a patient's symptoms? Let's get started. Let's talk about how to take a good history. Yeah. What are the types of questions? We're taught in medicine how to take a good history. I mean, I'm sure that your medical training was the same as mine. Like they beat that into us in terms of how important that history is. You have to get that history in, and it has to be in a certain format, and it has to be in this way. And so now that you are on this side of things and you see all of this stuff around trauma and stress in the body, how would you recommend people on both sides, medical practitioners and the therapists, taking a really good trauma history?
Well, let me just take a step back first, because in answering your question, because when we're thinking about the questions that we need to ask, right, we are keeping in mind our differential diagnosis. And for those of you who are not medically trained, a differential diagnosis is, what is the list of things this could be? Okay, what's my list? What's the list in my back of my head based on my experience, my reading, whatever? These are the top 3 things, 4 things, 5 things, 10 things, whatever. So
your working diagnosis.
That's right. Well, and the working diagnosis is certainly at the top, but then what else could this be, right? Mm-hmm. It's the list. And so neurology, we work a ton with differential diagnosis. And in order for trauma to be a diagnosis of exclusion, meaning that we've ruled it out, it must first be a diagnosis of inclusion, which means it needs to be on our list of differential diagnosis. It needs to be at the, I'm going to talk about the symptoms that can move it up or down on that differential diagnosis. But we as medical practitioners need it to be there because it's in many cases, in some cases, it's number one. It is the cause for all the symptoms, especially when all your medical investigations are normal, which we'll talk about because there's a limitation to those diagnostic procedures. But when we include it in that list, then we can start to ask the right questions. So when I was at Stanford, I did some research on looking at the symptoms that were coming up. And then as I was, seeing these patients over time and gathering information about their trauma history, and I used the ACEs questionnaire as a backbone for that. I wasn't giving it to everybody, but I would go through all the main questions through my history taking. So what I ended up doing is profiling the medical symptoms and their ACE score.
So just to make sure that I understand, like you're doing your regular medical history and you're including some of these questions from the ACE score, the ACE study, into your history. And you're asking them these questions.
I took a long time with my patients.
I was going to say, how did they respond to this? I mean, here's their doctor, and their doctor is asking them some very personal life questions. So did it take them back? Did it?
Yeah.
Like, what was the response?
Well, so here's the entree, right? Here's where it starts, because often they would volunteer it. Because as soon as I started to relate their symptoms, and I would say something like, sometimes when I see a lot of these symptoms that you're presenting with, it can be a sign of stress in the body. And the body is creating these symptoms because the nervous system is in a state of chronic stress. And I would go through some of the physiology briefly with them about the fact that our cognitive center is kind of shut down. So our ability to pay attention and learn is compromised. I would talk about the anxiety, right? I talk about the sleep. If you're, feel like you're being, if a tiger is going around your cave, right? When going back to caveman times, you don't sleep well, right? If you feel unsafe, you have insomnia, you can't fall asleep, or you have frequent night wakings because you're going to wake up and check. And so sleep problems are invariably a problem. The primitive nervous system is actually the digestive system.
I was going to say, let's go to the gut system. Like that's huge for people.
Chronic, your patient as a very good example. So chronic constipation, chronic abdominal pain, a mix between sort of loose stools and then constipation and that irritable bowel type of syndrome. That's very, very common. So what I was seeing is the stress response system involves our whole nervous system, the brain, the subcortical system, the autonomic nervous system, which is in the brain stem, which is creating our heart rhythms, our breathing patterns, and controlling digestion, as well as the information that's coming up from the body. And then down to the digestive system, into the somatic system, the part of the body that's, where we feel and our muscles. And so when you're starting to see multiple symptoms, attention problems, anxiety, orthostatic intolerance, sleep problems, constipation, and chronic pain, those were the kids that typically had a high ACE score when I got down to it.
And yet they were sent to psychiatry over here, neurologist over there, rheumatologist over there, immunologist over here. And it's so segmented.
I call it the medical merry-go-round.
Yes.
Right? Well, then the other thing I started noticing, and I started putting this in my talks, is the Far Side comic where everyone's touching a different part of the elephant and everyone's blindfolded. Mm-hmm. And they're like, oh, this is a, blah, blah. This is a blah, blah. And meanwhile, there's this like enormous elephant, but nobody's actually seeing the elephant. That's exactly what trauma is like in the medical system. Oh, this is migraine. Oh, this is vertigo. This is irritable bowel syndrome. This is POT syndrome. This is, all these things. But at the root of it, it's trauma that's causing this dysregulation across the nervous system and across all these different parts of our body that are not functioning at their optimal level.
Mm-hmm. So when you talk about trauma then being a diagnosis of inclusion, like you're really seeing a syndrome of symptoms. You're seeing a constellation of symptoms. And especially when you're seeing it across multiple systems in the body, for you, that's telling you, I think we have nervous system dysregulation at the core of this. And this is really a diagnosis of inclusion of these symptoms in with the trauma.
That's right. Well, and because the problem in medicine is if we're just treating a migraine, right, with all these different anti-migraine medicines, and then we're going to treat the constipation with, a Miralax or whatever. So we're treating these sort of individual symptoms. It's kind of like treating pneumonia with acetaminophen, with Tylenol, right? You're treating the symptom, but you're not treating the underlying problem, which is the nervous system dysregulation, which is the trauma dysregulation. And so in not recognizing the trauma, we are not treating patients. We are treating the symptoms on the surface, the fever or the migraine.
And like this is so good because one of the analogies that I work with as well is a house that's burning, right? It's on fire. But what is the symptom of that? Well, you have all the smoke. And so if you're going to try to treat the symptoms, you would bring in big fans to just blow the smoke away. and I feel like, right? Brilliant when you're looking at the symptom level.
Sure.
And yet when kind of like, trying to treat pneumonia with Tylenol, I feel like with trauma in medicine, it's even beyond that because when we don't even acknowledge it, it's not that we're just ignoring it. It's almost perpetuating it. It's almost making it worse by, and we're blowing fans on fire.
Yeah. 100%, the story that you told about the endoscopies and all that, I've seen it too. And, we talk about Munchausen by proxy, right? Where the parent is actually creating it. We don't have a word for it, but I've absolutely seen it where the medical physicians are creating this disease that the children that I saw, we're creating it with all these crazy tests. And when they're normal, and this is the key is that the testing is looking for a structural problem, right? It's looking for a physical problem. And, we do EEGs for electrical problems or MRIs or looking at the gut. And the problem with trauma is that we aren't looking in the right place. The trauma is sitting in the autonomic nervous system, and it's sitting in the wiring of the limbic system, the subcortical system. And we don't test that. Not right now. HRV is one of the few ways that we can really start to look at the autonomic nervous system. It's not specific in any way for trauma, but if we can start to look at heart rate variability and what's happening at the level of the autonomic nervous system and the vagus nerve, that is one of the few ways that we can actually start to really look physiologically what's happening under the hood. But MRI and endoscopy is not going to help.
No, we've got to measure it differently. We've got to measure trauma differently than the other tools that we are measuring other stuff with. And one of the things that I'd love for you to touch on, because again, like this is music to my soul. Like it's very few people that I can have this level of conversation with about the nervous system. So I'm loving this. Thank you. What a gift. What a gift to me. One thing that I see happening is still the focus on the central nervous system in trauma rather than the autonomic nervous system.
Yes.
And so
that,
let's go there. I didn't plan on that, but let's go there.
Well, it's interesting to me when I look at PubMed and look at the research papers and the autonomic nervous system. When I started to really dive into the research, there was quite a bit in the 90s about the autonomic nervous system and people exploring that. in the research. But as soon as we discovered neurotransmitters
Right?
and SSRIs, right, our
Direction,
ability
squirrel is over there.
to therapeutically alter the neurotransmitter levels, right? All of the research dollars went into neurotransmitters. And the autonomic nervous system kind of fell out of favor. It was like, oh, that's not very sexy. That's not very neurotransmitters. And we can make money.
Medications.
Medications. So that's how I see it. And we are starting to, I think there's more and more people are starting to look at heart rate variability in the autonomic nervous system. But, we still don't have a great way to measure it. And that's, I think, one of the frustrating parts for medical practitioners, because they want to know, like, I want to see evidence of this.
It's true.
And I think in some cases people have been burned. You hear about cases where the symptoms have been that the stress, right, was inappropriately seen as the problem and minimized, right? The symptoms are minimized. There's not a real problem, that this is stress. Right. And I think that we can get into a lot of trouble that way on a number of accounts. Number one, sometimes it's not true. Right. And so for me, when I'm seeing multiple symptoms, right, and I'm not coming up with a diagnosis, and there's no known history of trauma. Now, sometimes we know it. If this is a child who's adopted or was in the foster care system or is a refugee, or, has a known history of trauma, was in a wildfire or something like that, right? Then we can say, we can put two and two together. Okay, they've got all these symptoms. We have this history of trauma, boom, right? If we go into this idea of like chronic stress, is there anything that, that could be causing this chronic stress? No. Everything is fine. Everything is wonderful. Looking at the relationships of this child, okay? Because trauma, those kinds of traumas are typically interpersonal and they're under the surface. So either there's attachment trauma with a parent, and sometimes that can be the parent is depressed. They're there.
There's many types of ways to have attachment trauma without it being a bad parent.
Absolutely. Sometimes parents are working too hard, right? Sometimes we've got both parents out of the home and the parents being raised by sitters. Sometimes there's sexual trauma, and that has happened, and is invisible. You're not going to see that, but invariably those interpersonal traumas are going to affect their ability to make friends at school, their ability to relate to people, their ability to feel comfortable in a social setting. So if you're seeing someone with multiple symptoms and they can't form healthy relationships with their peers, they can't form healthy relationships with partners, they don't have a healthy relationship with their parents, then that to me is sort of the censure of this diagnosis, where I think I'm really dealing with trauma here. And it's important for physicians to know that you don't have to identify the trauma in order to help your patient.
Yeah, and I'm glad you're bringing that up.
Mm-hmm. Yeah, in some cases you will, and in some cases I've had patients come to me and say, I don't know what the problem is. I really want to know. And I sit there and I do the ACE questionnaire with them. And at the end of it, they have an ACE score of 6 or 7. And then we can say, this is, you have developmental trauma disorder. Like, this is your diagnosis. And they go, like, how come no one ever told me this before? Right?
Because it's impacted all of my life.
And they want to know.
Yeah.
They really want to know. And then there's patients where their medical symptoms are a protective mechanism for the trauma. And so starting to peel layers off of that prematurely can actually cause more harm than good.
Yes.
And so we as practitioners, I think, it's tricky because I've been doing this for a number of years now, and I understand trauma in a way that I didn't before. And that was one of my big questions as a clinician when I was still at Stanford. Do I need to know the history? Do I need to know the trauma history? And I will be honest, in some times, and Bessel van der Kolk talks about like voyeurism, this idea of like, I'd like to know, right? I'm curious. And that's where our own personal work is really important, to be able to put that in check and be like, is this a curiosity that I'm trying to feed here? Can I help this patient without actually knowing the story? Because they're not forthcoming with it. So I can see that their nervous system is dysregulated based on these symptoms. And I can see that they have relationship problems. So those two things, this is probably what I'm dealing with. And then I can start to talk to them. I will talk to them on a very superficial level about stress.
Sure.
And invariably, just the fact of all those medical symptoms is a source of stress. And so at the very least, you can talk to them and say, you know what, having all these medical problems and seeing all these doctors, that must be incredibly stressful. That stress is impacting your body. And they'll go, yes. And they don't even need to go to all those other places because
not ready yet.
They may not be ready, or it was pre-verbal.
Right.
They'll never get there. Sometimes it's intrauterine, right? When we start to look at the digestive systems and reflux, right? As adults, we recognize as a symptom of stress. What do we see in the NICU? Reflux. That's the number one problem in the neonatal intensive care unit is reflux. This is a sign of stress. So even intrauterine or perinatal stress can have an impact. And you're not going to get that in a history, right? They're not. You might get it from the parent's history. Yes, this is a child who was, born prematurely. Medical trauma is enormous. The number of kids that I see with congenital heart disease, with my list of symptoms, right? The sleep problems, the anxiety, the chronic abdominal pain, the chronic headaches, right? That's their nervous system is dysregulated, and it's medical trauma. It's all of their surgeries.
Yep.
So, and they may not be able to say this was traumatic for me, but we can understand that this is causing a physiological problem of dysregulation and creating symptoms from that. We can start putting two and two together.
And the medical trauma has been such an important piece that I actually had some of the somatic experiencing advanced trainers come and do a talk on the summit just on medical trauma. Because again, like those are life experiences that get wired into the nervous system that you're not necessarily going to have an explicit memory of them. And there's something that you said, Drina, that I'm going to take you back to, because I really want people to understand this concept that you talked about in terms of when medical symptoms might be protecting us from our own trauma and the pace at which one might need to go in diving into that trauma. And one of the things that has been most surprising for those people who have gone through my 21-day journey, which is a 21-day journey into their nervous system, where we start somatic work. So I bring in my trainings from somatic experiencing, neuroaffective touch for that attachment piece, and then a few pieces from here and there from some art narrative and some internal family systems. But we go on this journey into their nervous system in a very, very gentle way. And this is where we start. And it's only the starting place, right? Like you know that, right? Like you gotta start with the surface stuff. And they are always so surprised, Drina, because everywhere else that they've gone, they've talked about their story. And so for many people, they're coming in and they're saying, I either don't remember my story, or I'm not sure I want to talk about it, or why aren't we talking about it? And I'm saying, we don't need to right now. Like there may be a place for that. I'm not saying that the story itself is not important, but I'm also saying that we can do so much work on the nervous system without talking, because we need to go into the autonomic and work with the autonomic nervous system, actually be able to identify, hey, what state is my nervous system in right now? Is it in sympathetic? Is it in the freeze? Have I even landed in parasympathetic at all these days? Do I even remember what that feels like? And we can do all of that without talking about the story. In fact, I would say talking about the story gets in the way of us actually being able to notice what is happening in my nervous system at this very moment in time. So they're always surprised at how much they can shift in their own nervous system over those 21 days without even talking about their story, or like you say, not even necessarily knowing the story. Because how many stories have we all had, right? Like, how do we know which one we're talking about? I don't know. Yeah. And so much of what I like to share with my practitioners in my certification course is just this concept of the nervous system. It's like holds the keys to our life experiences. You can see so much about their life experiences, not know the details at all, but you see the level of dysregulation, and that's what you see. That's what you work with. Dr. Albers, thank you. I want to not only thank you for your time here, but also just for who you are. I know a little bit about your journey in medicine, and want to commend you for the courage that you have shown in the decisions that you've made in your career. And thank you for being that light in the world for us.
Thank you. Well, thank you for, creating these opportunities for people to learn and listen and connect to each other. This is it's a journey for all of us, and so I appreciate all your work in this too. Thank you.
And thank you for tuning into this episode of the Biology of Trauma podcast. I invite you to join us for this new community and movement for trauma-informed medicine for the modern health provider. We have created a LinkedIn profile where you can join us for information, resources, and discussion. The link is in the show notes. Please join us there on that LinkedIn profile. If you would like to know more information about how to recognize and work with trauma hidden in the nervous system, then I have resources for you. In the show notes, you will also find a link to the foundational journey. This is what you will want to do if you are ready for the real work and transformation. You're ready to invest the time and money that is needed to lay a foundation of regulation in your nervous system. On this page, I will have the information for how it already changes your biology. Because as we change our nervous system, it changes the rest of the system. So you start sleeping better, eating better, feeling less anxious, feeling less depressed, feeling more joy. All of this in the foundational journey. I will also have a link to Attachment Trauma Roadmap for the Healing Journey. This is the free guide I've put together to help you learn how your nervous system has been affected by your early life and attachment relationships. You will discover simple steps to rewire your programming in the nervous system for better relationships, feeling more secure and safe in the world, and thus how it will affect your health. I also have a do-it-yourself guided program where you can start to learn guided somatic exercises for stored emotions. If you know you have unresolved experiences from the past that you think might be affecting your health, then this would be where to start for 7 somatic exercises for stored emotions in the body. These are safe somatic exercises for you to learn and do on your own. And it is a great place to start, especially if you have any chronic health symptoms that get triggered with stress and overwhelm. Again, 7 guided somatic trauma exercises that you can safely learn and do on your own for the main emotions behind pain, fatigue, and other physical symptoms. There are some related podcast episodes that I can share with you. Episode 92, in fact, was on how chaos of our early childhood trauma affects our adult nervous system. That was with Dr. Tion Dayton. Episode 74, you'll want to check that out on why stored trauma becomes syndromes and somatic solutions for those with Dr. Peter Levine. Episode 72 is with Thomas Hubel on what have we missed with trauma-informed care. It's a discussion on boundaries, attachment, and generational impact. We've got YouTube videos, if that's your jam. 3 ways our childhood shapes our nervous system, what you need to do first before processing any childhood trauma, and how to actually safely process with a traumatized child. I am here to save you time and money with this podcast, to bring you practical information that will help you accelerate the trauma healing journey for yourself, for those you work with, and I would love your feedback. It is how I make this better. I am your host, Dr. Aimie, and until next episode, lots of love.